Just a couple of housekeeping rules that if you prefer English, you'll notice to the lower right, and Dr. Kidd has a screen that will emphasize this, there's a little global sign that says interpretation. You click on that, you'll have the option of English or Spanish. In our Spanish translations, we'll be having a simulcast through SVTV. Thank you, Bob Taylor, for making that available for us. Our two interpreters are Angela and Lorna, and so we're very excited to have them joining us. We also, while you're in that interpretation, if you can mute the original English so that you'll hear the Spanish more loudly, that's an option that you have on your own. As far as general housekeeping goes, I just want to say that we're going to ask that we hold all the questions to the end. At the end of the presentation, Dr. Kidd asked that we will either raise the hand or you can use the chat feature. We will be addressing questions and answering them both English and Spanish, so bear with us for those that are asking questions. We also want the translators to be able to ask the question again and interpret the answer. So if for some reason you have everyone has been muted, so we cannot hear anybody. And I think at this moment, we are gonna get ready to get going. This will be our 4th community update that we have given during the course of the pandemic. This particular update is focused on the latest and current information that Dr. Kidd has gathered. Most of it is going to fall on some questions that have been raised by the community ahead of time, such as the vaccine, the booster, what is the difference between a booster and the additional dose. She's also going to share with us some insights into additional data, where we stand with those that are vaccinated, those that are unvaccinated, and additional information. I am excited to be here. I'm hoping all of you are too. And with that, I'm going to turn this over to Dr. Kidd. And before we can, I am going to, actually, we might have a few words from our new CEO, John Henley. So without ado, John Henley, if you would be so kind to introduce Dr. Kidd, we would appreciate this if you're able to. I kind of caught him uncued, so he may not be able to.
Sorry, I can hear you now.
Okay. John, I'd like to introduce. Oh, I'm getting feedback here. I don't know why I am. John, if you're able to.
Yes, I can hear you.
Okay, if you can introduce Dr. Kidd, that would be great.
Be happy to. Welcome everyone, and I'm excited that we're able to come together this afternoon. We have the pleasure and honor to have one of the most highly educated and highly informed individuals in the Valley with us at Sonoma Valley Hospital, and she is always sharing her knowledge with us and with the community, and so you have the opportunity to benefit from that today. She blushes when I build her up, but her knowledge is invaluable, and so I don't want to delay any further you having access to what she knows, and that is our own Chief Medical Officer, Dr. Sabrina Kidd.
Thank you, John. Thank you, Celia. And thank you all for being here today. We're going to give you a little bit of an update on where we're at with COVID-19. I struggled to come up with a fancy title, so I settled on just the current state. It's been 1.5 years. We're all sick of this, and we're going to just talk about where we are now and try and come up with a game plan of how we can finally get out of this mess. As you saw here, the Zoom webinar tips, just to refresh for any late joiners, you do have the option of Spanish translation. Go to the bottom right-hand corner, your more, and select your interpretation in Spanish. So what are we going to talk about today? As I said, we're going to just do a brief overview of the numbers in the current state so we're all on the same page. And then I'd like to dive into vaccines. As you may recall, back in December and January, I spoke a few times on the vaccines and how they worked. We're going to do a brief simplified overview of that and then focus on some of the myths that I have heard, and I'm sure many of you have, over the 9 months or so since these came out. And we're going to try and break those down. Part of that is by exploring a little bit of the science behind these and how the mRNA vaccines, the Pfizer and the Modernas, have actually been 60 years in the making, not 9 months. We're also going to talk a little bit about the recent press regarding third doses and booster shots and try and break that down and about who's eligible, who's not, how we go about that, where, etc. Then a very important topic, our kids, how do we get them vaccinated and when? And finally, we don't want to leave anyone out. There is a third vaccine that's often not talked about as much, and that's J&J. So we're going to talk about some details and even some news that isn't in print, but came out today. And so we'll add that to this, at least in verbal aspects. I'd also then like to talk on the variants. That means Delta, Mu, Epsilon. What are all these Greek names and numbers mean? And what do they mean to us in vaccines? Then let's transition to vaccine mandates. And as I said, all of this to focus on what our game plan should be going forward, and finally answer any questions that you may have. So without further ado, what are things looking like? What is our national status? In the US, this isn't a pretty picture. We are at about 150,000 cases plus or minus on average per day in the US. As you'll see and probably know, there's great discrepancy between regions. California was recently taken off the very high risk. So we are the only state not to be in the very high risk. That means as a nation, we're doing pretty poorly. And why is this? Well, it's directly tied to our vaccination rate. It's not horrible, but it's not where it needs to be to get to the end of this pandemic. Early on, I think when we looked at this, we were hoping that we could get some sort of herd immunity with a vaccination rate of say 65, 75%. With the variants and other factors that have come to be, we now know that number needs to be near 100%. So we're nowhere close. All ages in the US, 54% are fully vaccinated. Remember, 12 and under are not yet eligible. So we break it down and look at those. 64% vaccinated. Unfortunately, that translates to another 35% that are not vaccinated, and that's a very important number. And 65 and up, a very high risk population, is doing a bit better at 83%. How are we doing a little bit more locally? So in Sonoma County, we are doing better than the national average. And in California, we're doing better than the national average. As far as vaccinations in California, we're now at 67% for 12 and up. That's the important number of those that are eligible. But remember, that's only 58% of our population. So the reverse number is always important. That's 42% that are still at risk. In Sonoma County, a bit better. We recently crossed a kind of important milestone, and I think it's actually up to 76% as of today. This slide was taken when it was 75% of 12 and up. But again, that's 24, 25% that are still unvaccinated, but on the whole, much better than the national and state averages. How about case details? We are coming off the peak of another surge, and I'll go into that in a couple of slides, but our current case rates or cases per day in Sonoma County is somewhere in the 75 to 80 cases per day, 7-day average. It fluctuates on the day of the week and with reporting. That is coming down. As you can see, the 14-day change, that's minus 62%, but that's still a 16 per 100,000 case rate, which is a lot higher than we've been or want to be. So another way of looking at this is to look at it in a curve state, and you can see our totals that we've had since the beginning of recordings in March of 2020. And if you look at the curve, this is from the beginning, January of 2021 through current. In January of 2021, we had a case rate per 100,000 residents of close to 60. And that we now have two curves here. The top curve is for unvaccinated, and the bottom curve, the purple curve, is for vaccinated. And you can see this is the big discrepancy and something we want to focus on. In April and May of this year, there were virtually no cases amongst vaccinated individuals. This was a kind of an opportunity miss, but something we need to work on and move forward with. You can see that we did have breakthrough cases, but as we'll get to in a bit, the hospitalizations and the severe illness for these was very minimal, if any, and mostly amongst individuals who had very severe other illnesses. The big story is these numbers, which were thought to be in the top curve of this Delta orange, that really an unnecessary avoidable peak from vaccination. So we are starting to come off this, but we are still quite high. And where we were probably in late February, or similarly, as we'll see in some other curves, hospitalization wise, we are still about where we were at our peak of August 2020. So now looking at hospitalizations, this is really our local impact. This is for Bay Area. And with the shared resources, it's important to look at the Bay Area as a whole. You can see that our first peak way back in March was quite small compared to anything that was to come. Little did we know that that summer would be just a peak of what was to come. Our worst to date has been the winter peak of last December and January that was very quick to spike and very quick to resolve. And then most recently, the summer of 2021, or the Delta peak, which was actually higher than the summer before. Important differences to note between these. The summer peak of Delta is largely a peak of unvaccinated individuals. So this is with vaccines available. But we are open. Remember that this is with California and the Bay Area wide open, versus last summer, the Bay Area was closed down. There were many, many restrictions in place, but there were no vaccines. So you can see here the impact of vaccines and masking and how we're able to have actually somewhat similar numbers. But again, this last peak is thought to have been largely preventable had we had a higher vaccination rate. Another very important part of hospitalizations to remember is that we aren't just talking about COVID hospitalizations. That's what this graph is indicating. But remember, those are beds and resources taken from other diseases. And really important to know that how this affects all of us. And when hospitals are forced to use those scarce resources on COVID patients, largely unvaccinated, which over 80% of the cases have been that are hospitalized, then there's fewer resources available for routine things such as heart attacks, strokes, and traumas. So really, even though vaccination may be an individual decision, it really does affect all of us globally and the resources that we have available. So we're going to get right into some things about the vaccines. And one thing I want to look at is that these are not new. That has been one of the myths out there that we'll get into in more detail. But mRNA vaccines, which are what Pfizer and Moderna have, are actually 60 years in the making. We'll go back to 1961 for the discovery of mRNA. And then we have almost 30 years till 1990, where therapeutics were first introduced and scientists expressed a therapeutic protein from mRNA. So they actually made it useful, is what that means. Years later, in 1994, they figured out how to replicate this. That's how what self-amplifying mRNA means. In 2003, they started looking at the possibility of having cancer vaccines. In 2007, they were able to further stabilize this engineering. That's a lot of what they've been working on, is how they could produce this, but how could they actually get it outside the lab and be able to use it? And then further to take that was 2010. That's when Moderna was actually founded, one of the big makers of our vaccine, and actually probably the most successful of our vaccines to date, was founded back in 2010. So a full now 11 years ago, but a full decade before it came to market. In 2017, they started looking at personalized immunotherapy, so looking at treatments for melanoma using mRNA vaccine technology. And in 2020, that's when we got our first 2 actual mRNA vaccines. So what many people thought was start in March of 2020 with Operation Warp Speed and get a vaccine out by December of 2020 was a remarkable accomplishment. But it was based on 60 years of research. It was something that was already ready to go. Why wasn't it put into production earlier? Well, previous to COVID-19, coronaviruses were not deadly. There wasn't a market for this. There wasn't the financial implications to bring this through, or to make a public health reason to mass market an mRNA vaccine. This became a reason. A pandemic became a reason to put that research to use. So it was really 60 years of hard research and testing and all kinds of efforts that went into making it possible to truly bring a vaccine to market in 9 months. So I've spoken previously in great detail about the vaccines, and here's a video to kind of demonstrate better than my words can how they actually work. So I'll pause while you can watch this. the memory is something very important to these. So as that video hopefully demonstrated to you, the way these work basically is by your body recognizing something is foreign. That's the spike. That's the little guy in there covered in spikes. And that's what the COVID-19 virus is symbolized by. Our bodies then builds up the ability to recognize that spike as something foreign, attack it, destroy it, but then importantly, it also creates memory so that years later or months later when we're exposed, our body goes, hey, I've seen this before. And it can again ramp up our immune system, recreate antibodies, get those levels up and fight off anything we'd be exposed to, which is how it prevents severe illness. So pretty remarkable technology using our body's natural powers to fight for us without having to get a natural infection. So it really mimics the natural infection process by giving you something that doesn't make you sick. And so let's then talk a little bit, since we know in the old news is that vaccines are out and that, you know, for Pfizer and Moderna, we need 2 doses. And for J&J, we need 1. Let's talk about the idea of third doses and booster doses. And we'll focus on that in some special circumstances next. So first off, what is the difference between a third dose and a booster dose? They're not one and the same. An additional dose or a third dose is to complete a primary series. A primary series is what we had seen as 2 doses, a first and second. For individuals that are immunocompromised, a third dose is what's needed to really be considered fully vaccinated, not from a legal sense, but from a clinical sense, because the difference is in these individuals, their immune response to 2 doses is less than that of a person who was immunocompetent or did not have these severe illnesses. So by nature of these individuals' pre-existing illnesses, such as having had an organ transplant, their body doesn't react as strongly to 2 doses, and they need a third dose to get to where most people are with 2 doses. So this is to level the playing field for those individuals who have special conditions. They get that dose at least 4 weeks after the second dose. So it's really 3 doses in 3 months, roughly, is the way to think of that. And that's what the additional third dose is for. This is only for people who have had Pfizer or Moderna. There is no third dose or even second dose approved to date for J&J. And it is only for those who are moderately to severely immunocompromised. As I said, and I'll go into in a minute exactly some of those conditions that are considered that. But in essence, it's for people whose bodies wouldn't respond well enough to 2 doses. And that is given 4 weeks after the initial second dose or later if it's been longer already. So let's compare that to a booster dose. That's mainly what's been in the news lately. The booster doses, just to start with, to be clear, none are authorized at this point. So what that means is the process is that the FDA has a committee that makes a recommendation internally to the FDA, who then in this case would choose to do an emergency use authorization, which is basically approval from the FDA to give this. That then goes to the CDC. The CDC takes that approval and makes further recommendations on a clinical basis for interpretation of how we're actually to apply this. So where are we at with this? Well, last Friday, the FDA committee met to make a recommendation. That was very well publicized. And what came out of that, what they voted on, was to recommend to the FDA that they approve a booster for Pfizer recipients only who are 65 or older and or those who are 16 or older and considered high risk for severe COVID-19 infection. So for that group only, that means no Moderna, no J&J, Pfizer only, 65 and older, high risk for severe disease. That recommendation now goes to the FDA, and they have the ability to do an emergency use authorization, or basically an emergency approval for that recommendation. We are currently waiting on that. We expect that in the next few days, but we don't know what that may look like, and it may be subtly different from this recommendation. One thing it may include, and we don't yet know, is they did not vote on, but there was a kind of a quiet recommendation besides this to include in that high-risk exposures. And that would mean individuals who work in high-risk settings, such as healthcare and teachers potentially. It is not clear whether or not that will be included in this authorization should it come. So we're additionally waiting for that information. Once that authorization or that EUA approval comes out, it then goes to the CDC, who will help further define it and give us guidelines on how to actually implement this. Those guidelines is where I anticipate getting further clarity on what a high risk for severe COVID-19 infection means. If I had to guess, it looks similar to what we saw when the first 2 doses were rolled out and we created high risk categories and when we were stratifying who would get a dose when they were in scarce supply. That is individuals who have diabetes that's not well controlled, severe heart disease, severe kidney disease, other illnesses that might lead them to be more ill should they get COVID-19. So overall, we think that there is likely to be some booster approval soon, but it will be for a select group of Pfizer recipients. It will not be a blanket approval, and it will be for people who are at least 6 months past their second shot. So given a little bit more on this, there's more controversy. It's not just about the FDA and CDC. Let's bring a third organization into this, the WHO. This is the World Health Organization, and they have a very different stance than those in the United States, or at least some of those in the United States on this. They are looking at this from a global pandemic, not from a US-centric approach. The FDA's job is to look for safety and efficacy, meaning does this really work? The CDC's job is to give guidelines. The WHO's job is to do this on a global scale. So different perspectives are giving us different guidelines. You'll see in the complicated text here, we're under conclusions, the full statement from the WHO, but the bullet points are on the left of their message. The WHO does not support booster shots. And their reasoning for that is the other 3 reasons here. 1, they do not believe it will stop the COVID-19 pandemic because these would not be widely available outside the United States. And unless individuals were to get vaccinated who are not currently, giving a booster to those who are will have little impact on the overall pandemic. Further, we know that there is great inequality in our world, and access to vaccines in this pandemic have only exacerbated those inequalities. We know that there are countries with only 1% of their population vaccinated and still struggling to get access to safe vaccines. We know there's been vaccines that have been developed in other parts of the world and released and then found to not really work. So they're having to start over from scratch. So the inequalities are enormous. And by giving boosters and spending resources on those vaccines in the US, that could further exacerbate those global inequalities. And then there's, among scientists are debating currently whether or not there's enough evidence to support their use. And what they're looking at is the outcomes. It's clear that giving a booster temporarily increases your antibody titers, meaning your immediate response. You build up antibodies, they're available to attack COVID should be infected in that immediate time. Over time, that will then naturally decrease, but your body will have memory. And should it interact COVID again, it would again build up those antibodies. So it's trying to understand what level of baseline antibodies are necessary to help get caseloads down in this pandemic, and whether we would get those from a booster. So does it have meaning to moving us forward as a whole, or is it solely in preventing individuals in the US from getting disease? Also, these vaccines were originally designed to prevent severe illness and death. The endpoint was not whether or not you got COVID, it was really whether you got hospitalized and died from it. There's been no decrease in the vaccine's ability to produce or to prevent severe COVID-19 or death. That is held up to date. So a booster isn't expected to change those outcomes. That is really what vaccines are aimed at. Thus, we're seeing a lot of debate over this topic currently. So a little bit more clarity on these populations as we go through this. As I said, for immunocompromised, what are those qualifying conditions? And these are the individuals that are currently on that 3rd dose, not boosters. Again, this is for mRNA vaccines only. This is for 12 and over only. And those conditions are actually quite severe in a very small percentage of our population. They're if you're in active treatment for some cancers, if you have a history of a solid organ transplant, meaning a heart or a kidney transplant, if you chronically take medications that make you immunocompromised, meaning your immune system cannot fight off illness as well as someone who is not in that state. That can also be from long-term high-dose steroids. The short bursts of steroids you might take for poison oak are not included in this. This might be because you've had a stem cell transplant, but only if that's recent. And it can also be if you have rare primary immunodeficiency diseases. or which is also thankfully rare today, advanced or untreated HIV infections. So again, this is a very small percent of our population, but very important that they be able to get this so that they can be on a level playing field with protection. What about our kids? So to date, vaccines are approved for 12 and older. That means that right now, thankfully, we have children in school again, but it's with a lot of anxiety, a lot of protocols, masks, et cetera, et cetera. So the closely watched is that approval for age 5 to 11 to get every school age kid vaccinated. We've recently gotten excellent news on this front, and we expect sometime in mid to late October that there will be the EUA, the Emergency Use Authorization, FDA approval for Pfizer for ages 5 to 11. So very exciting news. They just came out about 2 days ago saying that the study was complete and they used about a third of the dose they used for the older teenagers, and that it's equally effective with similar side effect profiles. So an incredible safety profile, very effective. And that should be coming out in October, so less than a month away. And so the resources will be gearing up to distribute those. Further, what about our even younger kids? It's also broken up into that 2 to 5 year old range. We don't have as close of an ETA for that, but we are expecting possibly by the end of 2021. It depends on how that trial finishes up and what that data looks like, but assuming things go as well as they have for the previous phases, we could see that by the end of 2021. I don't yet know what the plan is for newborns to 2 years old at this point. So the picture for kids is looking very promising. What about the J&J vaccines? We won't want to spend all our time on mRNAs. There is another excellent vaccine out there, and it only initially was 1 shot. This is such a debate that there was a recent New York Times article saying the J&J conundrum. What does that mean? It's whether or not people who had 1 shot should get another shot. And what data do we have to support that? Well, first off, the data is just now rolling in. And again, we got some very recent great news in this front. But I want to be clear that currently no additional doses of either J&J, Moderna, or Pfizer are approved for those who received their first dose of J&J. What do we know? We know that this was originally a 1-shot vaccine. And why was it designed that way? Because it was surprisingly effective. It was more effective than we expected any of these vaccines to be with 1 dose. And so the ability to get that shot into arms and offer 75% protection, which was the initial efficacy, was amazing. We just didn't expect Pfizer Moderna to be even better with a 2-shot regimen. So the data wasn't complete to compare apples to apples. So it's initially, yes, it was less effective, but was it less effective in the meaningful outcomes of severe disease and hospitalizations? Not really. So it is still a very great vaccine out there. What about boosters and additional doses? Again, they're not yet approved. We're still needing more data, but some of that is just now coming in. And we got great news today that they finished a study on second doses and found out that if you give a second dose 2 months after your first dose of J&J, it matches the initial data for Pfizer and Moderna. It's about 94% effective. So very impressive data. And they found out that if you wait and give it about 6 months after that first dose, it may even be more effective than the 2-month period. So incredible data that shows it stands up just as well. It's figuring out that proper dosing and the timing. So I do expect there'll be applications for additional dose coming soon, but we have not yet heard a timeline for that. What about the mix and match approach that's been talked about, whether you should have a mRNA vaccine of Pfizer, Moderna, and a J&J? Well, again, data isn't great for this. However, it has been done due to scarce resources in other parts of the world. It was done in Europe and Canada with AstraZeneca, which is similar to J&J. And it was thought to be safe. There were no major complications or drawbacks, but yet we don't have good data on how effective this approach is. It seems to do well from an observational standpoint, but we do not have a study proactively telling us percentages of breakthrough cases or things of that nature, or severe illness and death from the mix and match approach. So should it come? I think it's a ways down the road. And currently we're just looking at sticking with the same vaccine series that you started with in most cases. So then the final bit is a lot of people want to know, well, I get it, it's not approved, but should I try and get one? I would say that's a personal decision. I would say many of us know of individuals who have done this, and there are ways that you can self-attest to having a qualifying condition and probably get one. And I will say that that is definitely your own ethical decision to make, but their data is coming in, and we think that it will be available through approved streams in the near future, but it is not currently. So again, we've covered a lot of these, but I want to go through some of these myths one by one and just really break these down. These are great tools that I encourage, those of you who are vaccinated or ambassadors to the community or your families or whoever you know, keep these in your back pocket so that hopefully in a kind way, we can all find ways of using science to break down the myths that are out there regarding these amazing vaccines that we have easily available in our country. So the first off is that the vaccine can affect my DNA. I want to be clear, this is mRNA. It is not DNA. The two are not the same, and it does not pass on or affect you in that way. It boosts your immune system. It mimics what it would do naturally if you got an infection without you having to get severely ill. So it absolutely does not interact or change your DNA in any way. Myth number 2, the vaccine develops so quickly it can't be safe. So again, many people think that this started in March of 2020 and it came out in December 2020. How could something possibly be safe? It only had 9 months to be developed. As we reviewed previously, it was actually 60 years in the making. The technology was ready. All we needed to do was insert the spike protein information into the technology was already there and test it on thousands of people, which they did, and showed that it was beyond safe, probably the safest vaccine we've ever made and also the most effective. So amazing, and definitely not 9 months in the making, more like 60 years. What about myth number 3? The vaccine can give me COVID-19. Again, we often misinterpret with flu shots. We've known this for years, that people think they get the flu and they get the flu shot. Instead, it's that the vaccine is activated in our immune system. And when our immune system is activated, it can sometimes make us not feel well, meaning that we can get a fever, we can get body aches. That's all your immune system doing what it's designed to do. Those are cytokines, a fancy word that means that it's saying, hey, your body's learning to fight something off. This is actually a good thing. That means the vaccine's working. I don't want to worry you. If you didn't get those symptoms, it's not a bad thing, but the symptoms themselves are actually reassuring. They do not mean that you got COVID, and they definitely mean that the vaccine is working as designed. So again, this is one of the safest vaccine, if not the safest, developed. So although there are side effects, they are very rare that they would even need medical attention. Myth number 4, the COVID-19 vaccine can affect my fertility. I have a whole nother slide on this in a minute, so I won't go into too detail other than saying that it's actually the reverse. If you get COVID-19, you are at high risk of losing that pregnancy and of other problems, versus getting the vaccine has shown absolutely no increase in miscarriages or other problems related to pregnancy. So it has been endorsed by every major medical group and obstetrician out there, including the CDC. Myth number 5, I don't need the vaccine because I've already had COVID-19. Again, it varies incredibly of how we get COVID-19. We know people who have tested positive and never had symptoms, and we know people who have died from this and everything in between. And with that, we're seeing a very mixed picture of what people's natural immune response to COVID is. And so some people may have tested positive and really not developed much of an immune response, where others have a robust one. And there is not a great way or a blood test out there in routine labs that can tell you what your response is over time. Therefore, the only safe way is to proceed with going ahead and getting that COVID-19 vaccine to make sure you are actually protected. It's for yourself. It's to help us get to herd immunity. It's just a really necessary part. And hopefully you didn't have COVID-19 not to put it to good use in protecting others. So this is completing that cycle. Myth number 6, I don't need the vaccine because I'm young and healthy. I think early on, this was very much the way people saw it, is that I just want to get it and I'll recover from it. And then, hey, why do I need a vaccine? I'm young and healthy. I think this is starting to be broken down, as we've seen with Delta, is that even young and healthy are being hospitalized if you're not vaccinated We also know that young and healthy may not apply to people as they think it does. In the medical world, we often say that means you just haven't seen a doctor recently. So you may have undiagnosed conditions. It's also in America not highly realized that obesity is maybe the #1 risk factor for high risk for COVID-19 on the whole. And we know that Americans, over 50%, are considered overweight or obese, so that we have a very high risk population. So it really doesn't pan out. Age is not protective, although it is a risk factor additionally if you're older, but it's not protective necessarily if you're younger. So definitely we need that. We also need it to help us get to herd immunity. By you having the vaccine or by having infection, you also have the ability to spread it to others. So even though you might be able to fight it off, your loved ones may not. And that could include a loved one who's been vaccinated. We know that unlike previous strains, Delta can be transmitted among somebody who's vaccinated with a breakthrough infection. So if you're vaccinated and you get infected, you may have the ability to pass it on to others. So although it's kind of counterintuitive, it's a reason to get vaccinated and protect all of us, but that means we need every last one of us vaccinated. The exceptions will lead to more infections long term. Excuse me. Myth number 7, I don't need to wear a mask after being vaccinated. Again, we've proven in California, why are we the only state to come off the high risk list? It's attributed to 2 factors: higher than average vaccination rates and a mask mandate. So the masks decrease the viral loads is the way to think about this. If the person who has COVID has a mask on, well, then they're keeping more of that COVID to themselves and fewer viral particles are getting out there in the air or being transmitted to others. Likewise, if you have a mask on, your chances of inhaling those viral particles is less. If we all wear masks, the chances go down dramatically. We'll talk about later, if we decrease the caseloads, we decrease variants, vaccines remain effective, we end this pandemic. So this is part of the essential I think formula to ending the pandemic is continuing to wear masks so that we can decrease transmissibility and keep our vaccines effective until we can really get out of this pandemic. So I promised you a more in-depth slide on the pregnancy myth because I think this deserves a little more attention. I want to be clear that the CDC has actually declared officially that these are safe and gone further to say they are encouraged for all pregnant women, breastfeeding women, and including those who are thinking of becoming pregnant. Why did they go this far? Because they now have enough data to say there is absolutely no increased risk of miscarriage with the vaccines. There are 0 safety concerns with the vaccines in pregnancy. They do not affect the DNA of the mother or the baby. And the risk of pregnancy and COVID-19 infection is actually very high. So if you were to get COVID-19 while you are pregnant or in the peripartum period, you may have a more severe illness and a higher risk of miscarriage. Also a higher risk of preterm birth, which we all know could have devastating effects for all. So it's very, very highly recommended. And the evidence shows that getting vaccinated, if you are even thinking about having a baby or just had one or anywhere in between, is the right answer to protect yourself and your baby. What about vaccines and religion? This is a very controversial topic. I'll start by acknowledging that, but I also want to talk very frankly about what is known. And I want to say that many religious organizations, and these include large ones such as the Catholic Church, the Vatican itself, many Jewish traditions, they've all encouraged vaccination despite any connection to fetal stem cells. So they recognize that yes, Moderna and Pfizer have a link to being tested only. They are not used in production, but they were in the testing of a very distant fetal stem cell link. But that being said, all these major religious organizations and more come out daily have endorsed the vaccine and say that the benefits highly, highly outweigh any connection to fetal stem cells. I want to reemphasize that this is remote use only, and it's only in the testing of Pfizer and Moderna. There are no fetal stem cells in the production of those vaccines. And additionally, there's been concern for the use of pork products in some of these vaccines, and none of them are in those Pfizer, Moderna, or AstraZeneca vaccines. Further, it's just now coming out, but we've all recently learned that some people have done some deep dives into the testing of other common medications out there. Other medications used for COVID-19 treatment, including the remdesivir, had testing on this same fetal stem cell link. So the link is the same between accepting remdesivir and accepting the vaccine. Same with ivermectin, which has been falsely reported to help with COVID-19. It does not. It's quite dangerous. Reserve it for horses. That being said, ivermectin has also links to testing with fetal stem cells. And more commonly, Tylenol, Benadryl, acetaminophen are common over-the-counter drugs. There's more than 30 of the common drugs that you'll get at your drugstore. All of them have the same link as the vaccines do to fetal cell testing. And I think that's a very powerful message that if people are willing to accept those, that I would hope they would also be willing to accept these extremely safe vaccines, because based on this principle, the testing is exactly the same that was done in those compared to our common medications. So moving on from that, let's talk a little bit about some of the variants of concern. And what does a variant really mean? To sum this up, all viruses mutate, meaning they change over time. When something replicates, it has the ability to mutate. So it comes out slightly different when it divides and replicates and reproduces. Those are called mutations. Those mutations can give advantages or disadvantages. If it's an advantage, it may become the dominant strain. If it's a disadvantage, it would die off. So these lead to the slightly different strains of the same overall virus. These are only tiny differences, and that's what we call a variant. Some of these variants, as we call them, might be more transmissible, meaning they spread easier. Some might make you sicker, cause more severe illness, or some may be potentially resistant to vaccines, which is one of the big concerns we have and why it's really important to decrease the spread, because as I said, more replication leads to more mutations, which the worst thing we can imagine is then vaccine resistance. So recently, originally these were coming out as being identified by the place they were discovered or dominant. That has been changed for many reasons by the WHO to be by letter, so alpha, beta, delta, gamma, etc. Some of these then become variants of interest or concern, and that's because they become dominant or they have properties that are concerning, and those properties that are concerning may be that they're more transmissible, or that they make people sicker, or that they're more, they may evade vaccines. So Delta, otherwise known as B1-617-2, was originally not recognized in India. And this is now over 99% of cases in the United States. How did it become the dominant strain? Because it is over 200% more transmissible than the original COVID-19 strain identified in Wuhan, China. This is what makes it so powerful and has changed our pandemic this summer. Can it make more severe disease? We don't think so. The data on this is still coming in and it's complicated, and it may have a tiny edge in making a more severe disease, but overall it's fairly similar. It's just that we're seeing a lot more cases from fewer people. So the graph on the right shows you with the original strain, we thought that one person might on average give it to 2 people. What we see with Delta is it could probably give it to 6 to 8 people, if not more, depending on several different factors. So this is incredibly dangerous. And like we said, every person matters because one infection can multiply like crazy. And with this, we've seen that it means that you don't necessarily have to be 15 minutes worth of person or in a closed space. We're seeing Delta transmit with only brief interactions in open air spaces. It doesn't mean you need to worry if you're vaccinated and walking down the sidewalk and no one else is near you, but we all need to be mindful of in crowded conditions that this especially could be transmittable even in well-ventilated spaces. So how do we stop the variants? We have to stop transmission. More cases, as I said, equals more variants. Fewer cases, fewer variants. How do we do that? Vaccines are still the most effective way to stop COVID and thus the variants. Masks are very effective and they're, as I said before, essential to this, but the long game is vaccination. And why is that? Because although masks are effective, we all know compliance is an issue. Vaccines are 1 and done or 2 and done, or some cases maybe now 3 and done, but still that compared to wearing a mask every day in every situation is very different. We know that although extremely effective, for many, they're not sustainable and complacency becomes an issue. Likewise, with physical distancing, we know if we all stayed apart, that would be very effective. Again, not sustainable. We have lives to live. We have jobs to do. We have families to see. We're social beings by nature. That's just not an approach, as we've already seen. People are done with COVID. They want to be together. That is our natural instinct. So we know that that's not a long-term solution. And what about ventilation? Again, effective, but as we get more severe variants, as we're seeing with Delta, it becomes less effective. Outside is not necessarily the haven it once was due to the increased transmissibility of Delta compared to the original variants. So again, that's great, but it's not necessarily the long-term answer. And if you're in areas of severe climate, we know that when it's super hot outside, we don't want to be outside. If there's smoke from a fire, we don't want to be there. And likewise, if it's freezing cold, it's not safe to be outside. So we can't always rely on the outdoors as our haven throughout the world in this pandemic. That leaves us coming back to vaccines. So with that, and because of all of these vaccines that we've talked about and how effective they are and a game changer, there's a lot of mandates that have come out. The US rates aren't where we'd like them to be. So organizations are starting to use legal ways to get people to comply. They're starting to take into people's recognizing what is important to individuals, their work, their access to things of enjoyment, and mandating that vaccines, that you be vaccinated to enjoy those things. So some recent mandates that we've seen come out are for all California healthcare providers, teachers, first responders, law enforcement. Recent one on the federal level is going to be that all employees of facilities that participate in Medicare or Medicaid. So that is what it is going to take what California did as a state mandate and make all healthcare providers across the US basically need to be vaccinated. Likewise, the federal government is mandating this. They're also mandating it for their own. They did it for all federal employees as well as the armed forces. They're also, and we're not yet clear on all these details, but there's a mandate coming for all employees of businesses with greater than 100 workers. So this will be through some federal regulations that come out. So this is a very strong statement by our governments that vaccines are very important in order for us to keep businesses open and move on. Some local mandates that are also very important and want to make everyone aware of is this affects your ability to be with your loved ones as well, at least locally. In the state of California, hospitals are under a mandate that all visitors must have either full vaccination or a negative test within 72 hours of each visit. This means that if your loved one ends up in the hospital for COVID or for another reason, you're not going to be able to see them unless you're fully vaccinated. And if they're here for COVID, there's additional restrictions. So you likely would not be able to be with them even if you are vaccinated unless it was an end of life situation. So that is not a situation I want anyone to ever be in. We recognize that visitation and being with your loved ones is a very important part of healing. And I can't imagine something worse than being separated from your loved ones during those hard times. But this is now a state mandate because of the risk to all involved. And so another reason to get vaccinated. In addition, multiple local municipalities, and the numbers are growing daily, so this is probably already an outdated list, are taking this into their own hands and requiring proof of full vaccination in order to go to restaurants for indoor dining, bars and clubs, gyms, large indoor events, and any businesses or event that serves food or drink indoors. So I think Contra Costa County was the latest to join this. Previously, Berkeley did, as well as San Francisco, and New York and other places outside of California have also joined this, as well as several places in Europe. So I think we'll see more of this. And it's going to be increasingly hard to do things you enjoy unless you're vaccinated. So what is our game plan? If you haven't gotten to this point by all of it said today, the only way we see out of this is to get vaccinated. And in the meantime, wear a mask. And these are some photos from the vaccine campaigns that we've had throughout the last year. And I guess we just really can't say enough that we are very fortunate to have this amazing science and to have it to each of us free and widely available. So taking advantage of that and wearing a mask in the meantime is the only way we see forward. If you would like more information, here is a list of community resources. Our webpage, SonomaValleyHospital.org, has links to many of these and is a place you can always go to find the latest. We're putting regular updates on that page, as well as links to all the organizations. You can find the latest access to local testing, as well as to vaccination sites and updates through this page. So with that, again, thank you all for joining us today. And now we would like to open it up to questions. As we said before, you're welcome to type those in the chat or raise your hand, and Celia will help us organize that. Thank you for joining us.
Thank you very much, Dr. Kidd. Well, we do have a question already in the queue from the top. The question is, if an employee is not vaccinated and they need a negative test weekly, can it be at the employee's cost and time?
That depends a little bit on the municipality enforcing that. At the hospital level, no, it's at the hospital's cost. The California state regulations at this point, at least for healthcare providers, it is at the hospital's cost, and I believe that applies to many other organizations. So the testing is being absorbed by the organization, not the individual who's unvaccinated.
She's asking for a private employer.
You would have to check with the local jurisdiction for that.
Do we have any other questions? We do have another one that's come in. Acknowledgement. Thank you, Dr. Kidd. That was her, that's what they added on to that. Do we have it? You can raise your hand. You can, I've got a raised hand, so hold on one second. And we will allow her to, you can go ahead and talk, please.
Yes, I believe it's a person named Hoffman. If you had a question, you can unmute yourself and go ahead and ask that.
I'd like to know if you are under cancer treatment, is the booster available now, or they are still waiting for final FDA approval?
If you are under active cancer treatment, you are considered immunocompromised, and that is authorized for a third dose for those who have had Pfizer or Moderna. So that is part of the third or additional doses separate from the booster. It's currently available and authorized.
And where can you get that locally here?
You can self-attest to being immunocompromised, and you can get that at any local pharmacy. You can also go to myturn.org and search for sites there, depending on where you live.
Okay, thank you.
Oops. Do we have any other questions? Oh, I do have another question has come in. I sent in a question, which I guess you didn't get, but can an assisted living center require that they make a copy of your vaccine card for their records in order to visit my mother? Isn't showing my card good enough by itself? So this has to do with an entry point when you're coming into a facility.
I can't speak directly to the assisted living requirements if they're different from the hospital requirements. I can tell you that for a hospital, if you're a visitor, we are required to show it, and we actually have to keep record of that. So yes, we would have to notate, and we do in a log that has to be reproducible to CDPH, the California Department of Public Health, on demand for any visitors that have been there. So if they're asking for an actual copy of it and recording it, that is for definitely for hospitals, and I believe that extends to all skilled nursing facilities and other rehab facilities as well. So I believe that the regulations are the same. You could go to the CDPH website and they could confirm that. But yes, there's a state health order that requires not only for you to show it, but for the facility to keep record of that for all visitors and to have that be available at any time to the Department of Public Health. That is a state health order.
Thank you very much, Dr. Kidd. I do want to encourage people, if you would like to receive a copy of today's presentation, I'll be putting this in the chat. You can send us an email and we will send you a copy, both English and Spanish. Just specify what you're looking for. You can send that off to us. The Spanish simulcast and the recorded will be placed on our websites, and you'll be able to view it as well. I do have another question that has come in, Dr. Kidd. And the question is from Chase Hunter, who's asking, is there any reason why it may take longer for the Delta wave to recede than it took to rise?
There's a lot of theory about this, and the short answer is we think so, but again, this is uncharted territory. And the reason would be because of increased transmissibility. So with that's how sharp it rose, because it spreads so much faster. That also could mean that it takes longer to go away. Also, the may take longer to go away because we are no longer under restrictions except for mask wearing. So the world is wide open. People are intermingling. Kids are back in schools, and restaurants are wide open. All of these reasons could contribute to it not receding to the level it did prior, unless we're able to quickly get our vaccination rates up. So we do not know. We do know that it's starting to recede, at least locally, and we're not sure if that's a natural 2-ish month cycle that we've seen previously, or due to vaccinations and mask wearing, or a combination. So time will tell, but it's definitely not in remission nationwide, nor even locally. It's just very much starting to turn the peak. So increased vigilance is still needed.
Thank you, Dr. Kidd. We did have a hand that was raised, but they went away. I did get a comment from someone who participated. Dr. Kidd, they want to let you know that this has been excellent and very informative program. We are looking to do another one of these again in October. We'll be looking at some different options for information. Another Q&A has just come in, and this is from Lorelei Farmer. How long is the protection from the vaccine, as you stated, if I had COVID-19? It is unclear how long the protection will last.
If you had COVID-19, it's unclear to all of us how long the protection will last, and that's why it is advised that you get a COVID-19 vaccine. If you are having long COVID or other symptoms, you may wait up to 90 days after your acute infection to get that vaccine, but we do not recommend waiting any longer than that because the immediate protection from a symptomatic COVID-19 infection is really unknown beyond 90 days. So the recommendation is to get a vaccine on top of that, which would put you at least as good as those who have not had a COVID-19 infection and have only been vaccinated. So it's definitely, you need to get the vaccine. We do not have good data, and it seems to vary incredibly from person to person on their natural immune response to a natural COVID-19 infection. So the answer is please get vaccinated. Do not wait more than 90 days unless you're having a atypical long COVID and your physician advises that.
Wonderful advice. Thank you, Dr. Kidd. I have another question that has come in. If over 65 is approved, will the hospital organize another vaccination process as was done at the high school parking lots in January?
So at this point, we're waiting to understand what this is in the numbers. We don't have definite plans to organize as similar as that, but we will and are committed to ensuring that individuals have access to vaccines and that they are locally available. So we will be a resource for those. What that looks like is still in development. There will definitely be resources and further announcements as this evolves, and as we gather information on who will need this and what the impact are, will be available through our website. So please look there for updates. There are currently still at least 2 sites that are open and available in clinics in the Valley, and the information on our website, as well as local pharmacies. So there's ongoing current availability for anyone who's immunocompromised, and those sites have committed to continuing for any booster shots. And there may be additional sites which we would be supporting opening in the near future. We don't yet know the details. So absolutely, the hospital is here to support the community, and our website will be a resource for next steps. And we are still watching closely to figure out exactly what those will look like. We'll be supporting the community however we can through this.
Well, of course, Dr. Kidd, we're looking forward to making that happen again. So you've got all of us supporting you on that one. Thank you. I got another question again that wanted to clarify an earlier question. And her thing is, how long is the protection from the vaccine? That was her question. How long does the protection last? How long is the protection from the vaccine?
At this point, the protection from severe illness and death is indefinite. We have not seen any decline with those in the 9 months that they've been available, and longer for those who were in the original trial periods. So some theories, there's a researcher at UCSF that I followed closely, and some of them think that no boosters will be needed in order to keep that level of protection. There is still a lot of debate on this, so time will tell, but current data supports that protection from severe illness and death is ongoing for as long as we have data, which is about 1.5 years, 2 years, and theoretically could be several years. The infection against acute infection, meaning whether you get it with mild symptoms, may wane over time because you may not have as many antibodies immediately available, but that should turn it into a cold, which really we can't necessarily prevent through vaccinations, but we can through masking and other measures.
Thank you very much, Dr. Kidd. Do we have time for a couple more questions? Does anybody have anything that they would like to know that can range from distribution to administration of the event of vaccine itself? I think we suffice to say, Dr. Kidd, that we appreciate your time today. Thank you very much, everyone, for attending. Continue to look for notices. If you haven't already, you can come to our website and sign up to receive notices about this and other upcoming events that we have by visiting our website at sonomavalleyhospital.org. And there you can subscribe to several lists that we have for different types of information, ranging from community updates such as this to women's health, men's health concerns as well too. I encourage everyone to stay in contact, to mask if you haven't already. Hopefully you'll be inspired to be vaccinated. Dr. Kidd, any closing remarks that you have for us?
No, just thank you all for being here today. Spread the word, and every vaccination counts. So thank you.
Thank you very much. Goodbye, everyone.